So you've been told you have breast cancer. And there's a couple of ways that this may have happened. It may have been on a screening mammogram that led to a series of steps you may be familiar with that eventually led to the diagnosis, or less often it was found incidentally. But there's a couple of steps, right, that happen to diagnosing breast cancer. Generally, when somebody finds it, it's because they palpated or felt a mass and had it kind of investigated. But most people by far find it on screening mammograms, which are an annual way for women to be able to see if there's anything that's suspicious. So I guess let's start there. What are we looking for on a mammogram, and how does it help guide kind of the steps that we're going down?
Well, those are some good points that you mentioned. A lot of women, especially younger women who fall outside of the screening recommendations, they find their masses. It's a large lump and it causes a lot of anxiety, and they go see their doctor. But what most women who are diagnosed with breast cancer, it's on a screening mammogram. The previous year, everything was fine. The new year, the following year, something shows up. Fortunately, 85% of the time, something shows up. These women don't have breast cancer, but it does cause a lot of anxiety. It could be some shadowing or a cyst or some kind of benign process that shows up. And these women go on to have advanced imaging, whether it be more mammograms, ultrasounds, MRI. But that's where kind of the first of the diagnosis or the first recognition of something abnormal has occurred. Fortunately, 85% of the time or so, it's nothing. It's something benign, and we just do a routine follow-up. But unfortunately, 15% of those patients, they can have something that either needs a biopsy or something that's significant that we need to take care of.
That's reassuring. 85% sounds like, doesn't eventually lead to a diagnosis of breast cancer. So in that 15%, what's the first step that happens? Obviously, with any solid cancer, you need a biopsy, to where basically you get a piece of tissue to be able to look under and say, yes, this is consistent with cancer. In the cases of breast cancer, oftentimes it'll be that mass or somewhere in the breast. So what does that process look like?
So it depends on what was found. If it's something that's palpable, a lot of times we'll do an ultrasound-guided biopsy. If it's something that's found on mammogram, most of these patients will go on to what we call a stereotactic biopsy. It's a mammogram-guided biopsy. It's less invasive than going to surgery and having a big procedure done. And we can diagnose most cancers by minimally invasive procedures, ultrasound-guided biopsies, stereotactic biopsies. And basically what that is that we use either ultrasound or a mammogram to guide a smaller needle that goes in and takes samples of that tissue, or calcifications or something that's abnormal. It could be an architectural distortion. It could be some shadowing that stays persistent with some of the advanced imaging. And we guide those with mammograms or ultrasounds. And we use 3D mammograms now. It's very reliable. And we can get a very good, accurate diagnosis, or at least an idea of what the underlying diagnosis is of that thing that was found on the screening mammogram.
It's really good that we were able to detect things well. And before, when you got a diagnosis of cancer, it was very harrowing because a lot of times you found it a little later. So, while the incidence seems higher to people, like, oh, there's a lot of breast cancer everywhere, it's also in part because we're able to find it sooner, which also means in a curative setting. So we know anyone that hears cancer, you immediately think, do I need chemotherapy? And is this curable? And surgery across the board, and especially in breast cancer, is always the best way to cure a breast cancer that can be cured. Now, one thing that's very important, which we'll talk about, is the type of breast cancer greatly changes the direction you go on how to make it so that you have the highest chance of remaining cured. And we're going to get into what's called hormone status and triple negative, where you don't have targets. But it's important to understand that after that biopsy, that usually a breast specialist does, or a general surgeon in a community that does mostly things involved with the breast.
Correct.
Once they've gotten that biopsy, they're either going to determine that it's early enough to where they want to do an upfront surgery, that the data shows if you just take this out now, it looks like it's early, it hasn't gone places, and we can cure this. And then after the fact, you can look to see if it was a little more advanced than you thought. Or based on that initial evaluation, after the diagnosis of breast cancer, they'll determine some things based on the tissue from the biopsy, as well as some features we'll talk about with lymph nodes, to say, I got to send you to a medical oncologist, which is not a surgeon, but somebody that can help optimize or make that field shrink down, or even sometimes with the help of a radiation oncologist, if necessary, to then maximize the chance of cure. And then you get the surgery on the other end.
And that's true. And I firmly believe that breast cancer is a team approach. It starts with the diagnostic radiologist who diagnoses or finds something that's abnormal. Once that happens, and then it either goes in a couple of directions. It goes to the breast surgeon, or like you said, in a small community, there's a general surgeon who has dedicated himself to breast surgery. Or in some institutions, it's the radiologist who does the biopsy. Once that diagnosis is made of a breast cancer, then that goes usually to a breast surgeon. They kind of are the clearinghouse of what happens from beginning to end. So it gets diagnosed, goes to the breast surgeon. The breast surgeon will look at the pathology, will look at also the comorbidities of the patient, discuss with the patient their wishes and what's their long-term goals, age, and then we look at the science of the cancer. And like you said, we look at the size of the tumor. Is there any lymph node involvement? What are the receptor statuses of that patient? What are the overall big picture of this patient and success? Once we decide that, is this something that's going to be surgery first? Or is this something that's going to need surgery, chemotherapy, radiation therapy? And then, so it is the big team approach. And we are very fortunate that, especially in our practice, that we have a multidisciplinary team that, on some of these challenging cases, we have tumor boards and we discuss cases. And then if we find out this patient may need chemotherapy, either on the front end or the back end, and we'll also get into that at some point, then we can get the patient into a medical oncologist, also see the radiation oncologist. And if that patient is going towards a larger surgery, mastectomy, as opposed to breast conservative therapy, which is lumpectomy, and we'll discuss those more in depth, then that patient may need to see a plastic surgeon. And so it's this big team approach so that when that patient gets diagnosed, at some point within a quick time frame, they'll have a plan. And they'll have a plan that is tailored and tapered toward that patient. Every disease is different. Every patient is different. And so all cancers aren't the same. All patients aren't the same. And we find the best approach and the best treatment plan for that patient with that disease.
I love that you said that, because that's an important thing to understand. We see a lot of patients that, they hear stories from family members or personal stories, and it's very important to remember the reason all this collaboration happens between the surgeon, the plastics, and MedOnc, and everybody is all in the interest of cure. What is the best chance that we can keep this thing from recurring long term? And that collaboration wouldn't be happening if it was something that frequently we failed to be able to control. And that's the approach. And you really want to be knowledgeable. You want to ask the questions. And we're going to go over some things that, at least as far as pillars go, that put you in different buckets than somebody else that just has breast cancer. There's very distinguishing features that we basically put into 3 buckets. So we're going to go over those things, keeping in mind that you really want to know which one you're in, but then beyond that, it is very much tailored to your specifications. So Dr. Bonner, I appreciate you talking with me, and we're going to walk you through, again, all of these things that we discussed, and then maybe you can identify to bring back to your doctor so you best understand the treatment course.